Yeah, so I would really like to thank the organization for the invitation to join this meeting. And I did not put my phone out, so that is now done. My apologies. So I'm happy to join you. I already have some water with me also. I've celebrated my 60th birthday last Friday, so that's why my voice is a bit, yeah, so. I'm going to talk about childhood cancer survivors, as mentioned, and how are they doing and what can we do to support them. I'm a psychologist working in the Princess Maxima Center. So next slide, please. And this is as a small reminder that in the Netherlands, we have centralized the care for children with cancer, which means that after many years of treating children in 7 different pediatric oncology centers, we moved to one, which is the Princess Maxima Center in the center of the Netherlands in Utrecht. And we opened the doors in 2018. And I will tell a little bit more about the Maxima later in my presentation. So the next slide. So during my talk, I will share different things. I want to share first, what do we know? So background. And some general things, some general knowledge. And I want to share outcomes from the Dutch childhood cancer survivorship study, which is called the later study. Thereafter, I will share what can we do. So because my focus is very much on psychosocial outcomes, it's also about psychosocial care. And I will share with you our approach in the Maxima. So I will tell you a little bit more about our hospital and what we do. So first, I will go with you to the key knowledge of psycho-oncology. On the next slide, you can go. So these are familiar things, but it's always important to keep on reminding and repeating the background and the challenges of childhood cancer. What happens to a child and a family when the diagnosis is there? The diagnosis comes with frequent hospital visits, with medical procedures, with the treatment, and this also results in a lot of changes in the normal life, resulting in school absenteeism and restriction in social and sportive activities. And what we know is that this is causing stress, and this has effect on quality of life, short and long-term psychosocial problems, and also on medical traumatic stress. And I will talk more about that as well. Next thing, yeah. But we also know that if you look at this process, that adjustment and coping is very important in the process of children and families, how these quality of life difficulties and problems manifest themselves. And this is also where interventions come in. Next slide. We are all aware of the increase in survival the last 40 years. And this is absolutely a great achievement, and for families also very, very important, of course. But next slide. I do want to stress that even though the survival is increasing, next slide, next point, it does not mean that stress is going down. And this is an important thing, because we sometimes think, well, if you have a very good survival, that might result in, okay, that's hopeful, which it is also is, but still parents and children don't know whether they are the ones who will survive or not. So this is a key message I want to share. That next. The cancer is uncontrollable, and it will also always cause uncertainty. Next slide. When we are looking at cancer in children, we have to keep the developmental trajectory in mind, because diagnosis can come in different ages and treatment can come in different ages, and all these different developmental phases have consequences for children, how they are affected by their illness. And this is a background we always have to keep in mind when we are developing interventions. Next slide. When we are looking at the treatment and the diagnosis, we know that it affects quality of life. And there are many different models on quality of life, but it is important to keep these different domains of quality of life in mind. And we always distinguish the physical quality of life, such as motor and condition. We distinguish emotions and behavior. We distinguish school and work and cognitive outcomes. And usually the cognitive changes result in changes in school and work. And we have changes in social functioning, peer relationship outcomes. So if you ask, how are you to a child, there can be many different things which are affected for them. So it's always important to keep in mind how many different things you could ask about. Next slide. Also very important to keep in mind is medical traumatic stress. And usually when I'm presenting live, I ask the audience to raise their hand whether they know this term, whether they are familiar with this. And maybe you could raise your hand if you have heard about medical traumatic stress, and someone can tell me how many hands are up there. A few, or not a lot, or not a lot?
Not really half, maybe 1/3, I would say.
Yeah. And so how many people are in your room? That's also nice for me to know.
I think we're more than 85, because I had 85 shares, and they look like we had more shares. So around 85.
Yeah. Okay, thank you. Thank you. So I have a little bit of an impression. And so medical traumatic stress is key to keep in mind, because this is really, really important for children and families. It's considered a set of psychological and physiological responses to pain, injury, medical procedures, and the whole invasive, frightening treatment experience. And this can be different for everybody. So some children are able to cope and do not have a lot of reactions, and some have a lot of them. And it depends on what they experience, but it also depends on their reactions. And so the next slide, please. This is the medical traumatic stress model. And I want to share this with you because this is very important to keep in mind. Time. So there's a direct response of stress immediately after the diagnosis, and all families have an increased awareness of stress. Because they are reaction, that's a normal reaction to an abnormal situation. And if you press the button one time, we know that a lot of families, around 65-70%, are resilient. So there's increased stress, but they are able to bounce back, and they experience less stress over time. But there's also a group, next press on the button, there's also a group which remains stressed, but recover later. And then there is another group, next press on the button, which are stressed, remain stressed, it might even increase or continue to have stress. It is important to keep these groups in mind, because these groups also have an impact on how we distribute our care, and I will come back to that later. Next press on the button. It is also very important to keep in mind that medical traumatic stress reactions, or also post-traumatic stress, are subjective responses to a medical event. It's not everybody appraises the same situation the same as another one. So what we do see is that these trajectories are different for people, and these reactions are based on risk and protective factors of a family. Next slide, please. So if you keep these trajectories in mind, which I showed, you can also see this as risk groups. So we have a universal group of families and children and families who are distressed but resilient, and they need support. They need a lot of support. but they need something else than families who are, for example, in the middle, the targeted group who have stress, but who have risk factors present and remain stressed. That we have to provide other interventions to them, as the same as the above group, which is around 15 to 20%, which are families who remain stressed and have a lot of risk factors. Next slide. And so if you think about risk factors, risk and protective factors, I always use this model. It's pretty simple, but that usually helps to remember it. So in this model, you have to keep in mind, we are looking at a child with a family in a medical setting, and we are looking at children with cancer. And if you look at the right side of the slide, psychosocial outcomes, these are usually outcomes we study, and in studies we look at how are they doing. And we know that how are they doing is dependent on several variables. And these come from medical and social determinants, which is depicted on the left side. So that is what children and families bring with them when they come into our door. They might be a family with a pre-morbid, they might have difficulties before they came in when they were diagnosed. They have they come from a particular background. The child is young, or it's older, it's a teenager. They have a personality which they bring with them. And the medical context, the diagnosis they have will also bring a particular treatment. It will be different having a brain tumor, obviously, compared to having a leukemia diagnosis. And so all these medical and social determinants, we are looking at that a lot in studies. To see how children are doing, if they had surgery, or how they were doing chemotherapy or particular treatments or particular diagnosis. But in the middle, it is very important from a psychological point of view. These are the mediating factors. And this is the risk and protective factors, and usually protective in terms of coping, social support, cognitions, things we can also do if you look at the middle. So if you can press the button twice, we see what we can do, mediating factors in the middle, in a medical context, what we can do to support children and families, to provide education, communication, to decrease medical traumatic stress. And the other arrow pointing at the neuropsychological outcomes, that is also important, because we know that neuropsychological outcomes are more than psychosocial outcomes, depending on medical factors. So the treatment, radiotherapy, surgery for children with a brain tumor have a lot of consequences. And the neuropsychological outcomes are also a predictor of psychosocial outcomes. So if you look at this model, you could say if you have difficulties with concentrating, this would result in a lower quality of life. Next slide. So in summary, the key knowledge I want to share with you: cancer will always be stressful, no matter the survival rate. Medical traumatic stress should be prevented and treated. It is very important to be aware of medical traumas and prevent it with interventions. We also know that psychopathology is not the rule. We have a lot of resilient families. It is rather the exception. And medical determinants are not among the most important determinants of psychosocial outcomes, except for the brain tumor patients. And factors which are really protective for families are social support, coping, resources, and care we provide. So that is where we have to put our interventions. So before going into more detail about the interventions, I want to share a little bit about the survivorship study we did, next slide, in the Netherlands. And I want to, next slide, I want to credit my PhD, Anne Maas. She has been working on this last 4 years, and she will defend her PhD soon. Next slide. And in her study, we looked we have seen that there are gaps in the literature, because a lot of studies have been about generic psychosocial outcomes, while survivor-specific outcomes were not captured. And positive outcomes were sometimes overlooked. And next point. Because we know that patients or survivors sometimes say that the cancer also helped them become a stronger person. Next. And there has been a strong focus on the socio-demographic and medical histories as risk factors. So the left side of the slide, which I shared with you, of the model, but less focus on if they had late effects, what did it mean? And also not that much on psychosocial risk and protective factors. So she studied this in a large study. Next slide. So we had 3 periods in the Netherlands where we studied survivors, and we created a later database with a lot of medical history. We asked them in the first period in 2013 with questionnaires about their functioning, and we had a big clinical study, the last one from 2017 to 20. And so in this study, we looked at psychosocial outcomes, which was with questionnaires. So we asked them to fill in a lot of questionnaires, and we looked at a lot of background variables, so risk and protective factors, which came from treatment and socio-demographic, but also we looked at clinically relevant health conditions. These are health conditions that were symptomatic and for which they had a medical intervention. So late effects, which really were a result of their treatment of cancer. And we looked whether they had, yes or no, had these clinical relevant health conditions, and a number and a type and click. And also we looked at these types of late effects, so secondary cancers, but also cardiac difficulties. You see the list there. And then we also looked at the psychosocial risk factors, which were also with questionnaires. And you can see we looked at perceived benefit and burden. We looked at illness cognitions to self-esteem and to social support. And now I will take you through the study. Next slide, please. So this is the Dutch childhood cancer survivor study, which was conducted, so the big study in 2017. And it's important to keep in mind, these were really older survivors. They were diagnosed between 1963 and 2001. And they were all invited to the clinic, and they participated in different sub-studies. And one of them was the psychology sub-study on which I am talking about. And so in the end, we had almost 2,000 survivors participating in our questionnaire study. Next slide. They were around 36 years of age, females, half of them. Employed, there were 85% partnered, 78%. And the highest completed education was middle or high predominantly. Next slide. We had time since diagnosis, meantime, almost 30 years. So like I said, they were early diagnosed. And we had diagnosis from different backgrounds. You can see the slide CNS tumor, which is the little gray. And we do think there were a little bit less CNS tumor patients, survivors participating because they might have had difficulties with filling in questionnaires. So the results, next slide. Psychosocial outcomes. On the slides, you see the references where it has been published. Next slide. And here you can see we looked at these outcomes, so these psychosocial outcomes. The orange is the survivor group and the blue is the reference group, so norm data. And what you can see is differences. Next click. We saw a significant difference in the two groups for depression, and it was lower. So we had lower depression for the survivor group, and in the other outcomes there were no differences. And you have to keep in mind, and that's also important for the next slide, we use effect sizes. And effect sizes are the difference in standard deviation. And we we have small, medium, and medium effect sizes. And on this last bar, you see the post-traumatic stress disorder, and we had very low incidence of post-traumatic stress compared to reference groups also. Next slide. Here you see the results for health-related quality of life, and this is the 36. And again, you see that the orange bars are very clicks, please. We saw differences between the survivors and the reference, so the general options, and one more vitality. So one more click. Yeah, so there you see, and these were medium effect sizes. So overall quality of life was good. So next slide, we looked at the survivor-specific outcomes, and this is not possible to compare to healthy controls because this is very specific questionnaires. We use two questionnaires. It's the benefit and burden questionnaire and the impact of cancer. And both these questionnaires have positive items and they have negative items. And if it's a positive item or scale, it's green. And if it's a negative items or scales, it's red. And what you can see here is that in general, all the survivors scored higher on the positive domains. So positive socializing, health literacy, body and health, they had impact, but not very much. And if you look at the red bars, you see thinking and memory. That's the negative outcome they experience. That's what is rated highest. That is important to keep in mind. So they suffer from thinking and memory in general. One tick. What we see when we ask them about information, which was also part of these questionnaires, that almost half of the survivors reported to not have all information about cancer they need. So keep that in mind. I will come back to that. Next slide. So we looked at these outcomes, psychosocial outcomes, and we had physical, we had social, cognitive, and emotional when we were looking at all the different questionnaires, and we looked at the risk and protective factors of psychosocial challenges. Next slide. So we used different models, and we first looked at what do the social demographic factors contribute. And this is now depicted on the slide. You see that these were all rather small to medium effect sizes. And this was adjusted for some background variables. Next tick. We saw that up to 15% of the variance of the psychosocial outcomes was explained by the social demographic and the medical history, because now we added a medical history. That is what you see in this slide. And here you see that we only found a medium to large effect size on the emotional outcomes when they had an unspecified diagnosis. And we did find for the CNS tumors, we found small to medium effect sizes. So here it's a bit of a summary. We tried to summarize all the findings because we had a lot of findings. But it's important to keep in mind that if you put only social demographic and medical variables in a model, it only explains 50% of the variances. So then thereafter we looked what would the health conditions add. So next slide. So the health conditions, when we looked at that, the presence of a health condition or the number of the health conditions were only small to medium effect size. So no big contribution of this in explaining psychosocial outcomes, because that's what we are talking about. Next click. But we did see that there were larger associations between specific types of health conditions and psychosocial outcomes. And these were, next click, the following. If patients had a second tumor diagnosis or these other conditions, the effect sizes explaining psychosocial outcomes were medium to large. So it's especially these outcomes, but not the presence, yes or no, or the number of health conditions. So this was very important for us to find. That these specific late effects are important to keep in mind when you look at psychosocial outcomes. Next slide. And then we added the psychosocial risk and protective factors. So the perceptions, the illness cognition, self-esteem, and social support in the model. And here you see that these contributed more, and the explained variance also increased a lot. So if we want to explain the psychosocial outcomes, we have to look at self-esteem, we have to look at feelings of helplessness or negative perceptions. These are very important. Next slide. I also added work we did on the fatigue, because fatigue in survivorship is also very important. It's very distressing, it's very common. And here in this slide, you see also from the Dutch Later study, but this was the fatigue study. We see, if you look at the left bar, it's the sibling bar. On the left, that the fatigue in the different diagnosis groups are all higher. So there's a lot of fatigue in long-term survivors. Next slide. So in conclusion about this study, we see for psychosocial outcomes, so the outcomes, similar mental health and a bit worse quality of life on health perceptions and fatigue. They do have survivor-specific worries, and they also experience positive outcomes. Next click. And this is generic. And then next click, the other two are survivor-specific. And next click. What explains psychosocial outcomes the most? The way they perceive it and how they cope with it, and the resources, self-esteem, and social support, and the type of health condition that childhood cancer survivor has. Next slide. So key message of our is that how they perceive and cope with cancer and its aftermath better explains their psychosocial functioning than their medical histories. And this is what we have to take into account if we look at psychosocial outcomes. Next slide. And it has implications, and so we promote a step model of psychosocial care in line with the risk factors I shared with you before, because this matches the risk of a family, the interventions they need. So if there's no clear identification on risk factors, monitoring in survivors and attention for fatigue is important. We have to information and psychoeducation to all survivors in an early stage, because actually interventions, prevention is key, and it all starts at the beginning. And if you have more factors, subgroups, like the secondary tumor or the psychosocial challenges, it's important to target the interventions to if the mild psychosocial problems, or they need advanced care with more severe psychosocial problems, to refer them to the network. Because we know, and that is also the topic when I continue about interventions, we know we cannot provide everything in the hospitals. We have to refer them outside. And this also is also in line with what we see with neuropsychological problems, for example, with brain tumor patients. We can provide some support in the hospitals, but in the end, we have to refer them to networks with specific interventions for their problems. So, continuing, what can we do? I already talked a bit about it. The next slide. Next slide. So in general, it is important. So this is a bit in general, what can we as hospitals do in general? Use a step model of care. So use this risk model, which I've been showing. In terms of psychosocial outcomes, interventions should be framed to promote competence rather than reduce psychopathology, because that is what our outcomes tell us. And we need preventative intervention. Survivorship care starts at day one. The key is prevention, also with medical traumatic stress. You can use implementation of standards of care and use guidelines. I will tell a bit more about that. If you use guidelines or standards of care, many standards, they use patient-reported outcomes or questionnaires to assess something. So you need to have an infrastructure around patient-reported outcomes. And obviously, internet is promising. So if you look, next slide, for example, also in our hospital, a psycho-oncology team could include child life, play therapy, social work, and psychologist, and you would level them according to the levels of risk of family. So there is a lot of prevention of problems to reduce medical traumatic stress by having child life play therapists to support children in medical procedures. Families need social work to cope with everything around what's happening. And the children who have real severe problems could be referred to a psychologist. Next slide. I mentioned the psychosocial standards. These are 15 psychosocial standards. These have been developed 15 years ago. 2015, not 15 years ago. And I want to point to the monitoring and assessment of neuropsychological outcomes. That's one of the standards to follow, in particular, children who are at risk for this, and which include brain tumor patients, which means to test them on a regular basis. But this is time-consuming and expensive, but it is a very important. Next slide. Yeah, so the development of the standards has been with reviewing existing literature. There has been think tanks, and they did peer review and a lot of publications. Next click. So there have been a lot of studies in these overview papers. There are 16 papers. Next click. And this is where it is available. So keep these standards in mind. But also, next slide, keep in mind guidelines, and keep in mind the International Late Effects of Childhood Cancer Guideline Harmonization Group, the IGHG. They have a website. For example, they have a recommendation for surveillance of cancer-related fatigue. And they, for example, advise to use Bromance questionnaires or the PSQL multidimensional fatigue scale. Next slide. What you also have seen, monitoring and screening is important, because if you screen and monitor, you can recognize psychosocial problems early, which leads to less severe problems and better adherence and less stress on the staff. Next slide. So I come back to this model again and again, but it's a very important model. There's also a questionnaire which is able to assess these risk and protective factors to psychosocial outcomes. It's called the PET, the Psychological Assessment Tool. And it has different domains: structure and resources, family problems, social support, stress reactions, child problems, sibling problems, and family beliefs. And these are all measured. And they come to, with the use of these questions, you can estimate where a family is in the pyramid. So whether it's universal, targeted, or clinically in terms of risk factors. So next slide. Next slide. So it's important to keep in mind that this is available. It's a brief caregiver report screener. It's based on this model, and it is already translated in a lot of different languages. So keep it in mind for your hospital. So I would like to go to the last part of my presentation, what we did in the Maxima. And I realize I talk fast, I have so much to tell and love to share with you. So next slide. So in the Maxima, this is it's a picture, by the way. It's not a real picture. But so the focus in our center is on increasing survival by centralizing the care with a good quality of life. Next slide. So what is the Maxima? What does it mean? We have 85 hospital beds. We have around 80 new patients which are strictly newly diagnosed and 200 relapses per year. So that's the Dutch number of newly diagnosed patients. We distinguish 4 care units, which is hem-onc, neuro-onc, solid tumors, but also we have a quality of life department. And we did a lot in this new hospital on the environment. And one example is the child-parent room, which you see on the picture. All children have a room and a connected room of their parents to it, and also a balcony so they can go outside. And there's lots of areas where we try to stimulate activities. And this has all been built together with the parent organization. Next slide. So under the umbrella of the Department of Quality of Life, we have departments medical psychology, social work, and child life. We have developmental care, which is a lot about TLC, like activities, but it also has the school services, sports and movement, supportive care, late effect clinic. And we have 4 group leaders. Research, which are supportive care, late effect, psycho-oncology, which is me, and neuropsychology, which is Mariette Partenen. And some of you might know her. She is a lead group on this area and, is doing research in the area, which you will talk about today as well, I guess. Next slide. If you think in terms of providing interventions, what can we do? Psychoeducation is key because you should provide informational material from acute diagnosis to follow-up to late effects. And different things are possible. And I think it's a relatively easy to accomplish for any hospital. And it can also be shared. You can learn from others what they have. For example, we have for survivors, we have also a separate website with information for them. Next slide. Screening and monitoring systematic attention has been one of the things we have been promoting from the start. In the Maxima, we implemented this communication tool. It's something I have developed over the years, and I've studied this in very detail. But the idea is that a child fills in a questionnaire before the child goes to the doctor or the nurse, and the prompt portal provides items with traffic light colors and graphs, so it changes over time. And this can be discussed during the consultation. And the key is the systematic attention for this. So seeing what's happening and knowing what's happening over time and paying attention to all the domains of quality of life and not just asking, how are you? Next slide. So in our late effects clinic, we also did a study and we monitored this, we implemented this, and we also looked how the healthcare provider evaluated this, and it was all very positive, and it's now implemented in a late effects clinic as well, and it's been used very widely by all the, in the late effects it's running very good. Next slide. It's also important to pay systematic screening for parents, so you can use the PET, which I already discussed, and this is how it looks in our prompt portal. So you see the pyramid, and you can see if a family where it is, and on under the pyramid you see the bars, and these relate to the different domains of the questionnaire. And so you can see the longer the domain, the more risk factors are there. And so apparently in this family, the yellow bar is long, so there are the resources in the family are considered at risk. So they, for example, might have financial problems or no support around them. We also have a distress thermometer for parents we use as well. Next slide. Also important is psycho-oncology and teaching, because we can only improve interventions and education if we provide psychological knowledge to medical professionals about the developmental psychology, about the children and family in a medical situation, about trauma-sensitive care and palliative care, and communication skills are very important. These are all very important tools to have in a hospital as interventions. And one click. And it all strengthens the universal care. So all the care for all the family members in the hospital. Next slide. And I'm almost coming to the end of my presentation. This is just a list of other things we do in our hospital. And prevention is key. Again, we have a group course intervention in which children and parents or survivors learn empowerment, so how to cope with the disease, the treatment, the social environment. We have a program which is called Move to the Max. It's from the Sports and Movement Department. And we have students who implement this. And the focus is to bring movement as much as possible. We all know that moving and activity is so important for physical outcomes, also for neuropsychological outcomes. So we try to stimulate children to move. We have a brain care program. This is the implementation of the neuropsychological standard. So we follow up brain tumor patients and other at-risk groups. And we have a prom core facility where we facilitate everything around proms, because patient-reported outcomes are everywhere in your hospital. They will be in trials, they will be in studies, they will be in care. And it's very important to align everything, because when you are following up on brain tumor patients, for example, in care, they will also be invited to be tested for trials. And it is really important we don't do things double. And we have put efforts in what we call the Kinder-Onconet. And this is a program providing and training external providers, because we have to refer patients outside our hospital. So coming to an end, next slide. I think psychosocial services are not a luxury, but a necessity. I want to stress that again and again. We can do a lot to support children and the families on the psychosocial outcomes. That was my main topic. I share with you this map of Europe, and that's related to my last slide, related to activities in PsyOp Europe. Let's get connected. There's a psychosocial working group, which is open for participants. And we also submitted with a large group of people an EU grant. It's called Impact Europe, and to take a look at psychosocial services, what is available, what is not, and what can we do to improve this. And if you want to be part of the network, please email me. That would always be nice. So I would like to end with acknowledgements. Many people in my group who participate in all the work to do. I always do things together, and with the patients, the parents, many people from the Maxima. And thanks for listening. And if you have any questions to me, they can be now, very shortly, or you can email me if you want something else. Thank you.
Thank you so very much.
I can.
There were warm applause here from Uppsala.
Oh, thank you.
So we have time for a few questions.
Could you quit the presentation, then I can see more, I guess.
Yes, so thank you, Martha. Ingrid Tonning-Olsson here. Thank you for your presentation. We have recently been translating the psychosocial assessment tool to Swedish, and we have also recommended the use of the psychosocial assessment tool in our national guidelines. Could you comment a little bit on how you use the psychosocial assessment tool in your clinical work? And do you give it to all patients? And when do you administer it? Do you administer it repeatedly or just one time? So just some comments on that. Thank you.
Yeah, thank you for your question. So the psychological assessment tool is basically developed to assess risk factors, risk and protective factors after diagnosis. So the assessment is thereafter, so within 4 to 6 weeks. We are implementing this, and we are actually in a transition phase to reconsider what we are doing, because we are our CLIC team, they ask the families to fill it in, and our social works, they take a look at it. And basically, we do all patients who are Dutch speaking. So important questions you have to ask when you are making your hospital implementation plan is who to screen, who do you want to screen, who is doing the screening, how will you do the feedback, will you share it in your multidisciplinary team, will you share it with the pediatric oncologist. You really have to make a plan. And NAG-TSK from America, she's working on an implementation toolkit for others. And I can also offer you some sort of guideline where you can think about what you can do, because there's like a sort of steps you can take and with your team make a decision, how do we want to do this? Because there are many different decision things in there. Actually, we are was sort of lacking in our hospital. We are only including the Dutch families, so Dutch-speaking families, which is, well, if you want to be inclusive, we need other languages. We do not give feedback to the families. So in America, the families who fill in the PET get a letter where they are in the risk pyramid, and we do not share the PET with the multidisciplinary team. So only the psycho-oncology knows about the score, and they act upon it. So they do know this is a high-risk family. They provide more support, but we want to make changes in that.
Thank you. Did you say you had a list of things to think of when you...
Yeah.
Oh, could you please just
please
send it to me?
email me, then I can share it with you.
Yes, thank you.
So Päivi has a question here in the back.
Okay, thank you. I'm Päivi Lähteenmäki from Finland, and I just wanted to ask, you mentioned about the CLIC EQL, or what was it called? I mean, the electronic support system where they can give their thoughts or ask questions or evaluate, or how was it? But I'm curious about what is the age of the patient who starts to use the tool?
Yeah. If I hear you correctly, you were asking about the CLIC tool and the CLIC Prom portal, so the questionnaire tool.
Yes.
And the age of the patients. The children start filling in questionnaires when they are 8 years and up. So under the age of 8, 0 to 7, until 8, parents fill in proxy measurements. So we ask the parents to fill it in. And it's self-reported after the age of 8.
And have you have yourself created the tool, or are you using something like what is included in Promise or PetSchool, or how was the structure? I'm just thinking about the parents of very small children and the proxy questionnaires and so on. Maybe this is too broad question, but just to know.
Do you want to know which questionnaires we use?
Yes.
Yeah, we use the PeachQL, so which is a very generic questionnaire, but the benefit of this questionnaire is that the versions over time are the same. So you can go from 2 till 18 and even 18 to 30 using the same questionnaires, which is not always possible. It's very difficult to have questionnaires for all ages.
Yeah, thanks.
I have to move out of a room here, so I don't know how your program is doing, but more questions. Happy to take them.
So were you able to stay for another question, or do you have to move?
Yeah, it's okay. It's okay. I will just say that. Yeah, it's okay.
Okay. Any more questions out there? Yes. Please wait for the microphone.
Thank you for a very interesting presentation. If I understood you right, you said that 50% of the childhood cancer survivor didn't have enough information of their disease. What do they lack the information, or do they request the information? Do they want to have information? And can you comment on From
in
your
mind.
perspective, what kind of information do they need? No?
Things by parents, by doctors, and they have different needs at different times. So sometimes their questions are very different when they become 18 or 25, and then they need to hear things again. Can you still hear me?
Yes.
Okay. So what questions? Many questions were around fertility. And that is an important topic because we also know that sometimes they have questions and they think they might not be able to get children, while that is not the case. They have not had a treatment which has affected their fertility. So it is very important to share information about risks they have and not have.
Thank you.
Well, then finally we wonder I mean, this is a difficult question, but if you would choose one thing to advise us on as we go forward with research within this field in Sweden, what would your advice be?
Have the parents and the children join you in the focus. So ask them also, because we think too much for them and we should not do that. So let them participate. And it depends a bit. I think the follow-up period, so between active treatment and survivorship care, is an understudied period. So I think, and also a period where interventions are lacking. And that's a period you should focus on.
Well,
I hope that helps.
Thank you so very much.
It was a joy to do it. Thank you so much for inviting me.
Yes.